That started me on a path of wanting to bring more resources together in an integrated fashion, break down silos between data sets, and also just expedite and support the efficiency of practices by automating a lot of things, by increasingly relying on electronic measures, and of course the internet. That was part of the impetus for me to want to create a GUI, graphical user interface driven methodology for capturing emotions and moods and other highly subjective experiences like pain, but doing so in a much more engaging manner. Emojis were coming along. You and I grew up in a period where we first began using emoticons by typing them, and then moved over to emojis. Emojis became the fastest growing language on the planet, and now we all use emojis.
Hello, everyone. I'm Arvind, your host and the CEO and chairman at Copper Digital. Welcome to another enlightening episode of Health Tech Innovation Trends 2024-25. Today, we are honored to have a distinguished guest, a trailblazer in clinical psychology and healthcare innovation, with a career spanning over 3 decades. Our guest has not only served as president of the South Carolina Psychological Association, but also paved diverse roles, currently serving as the Chief Science Officer at ADoH Scientific. He is the co-inventor of the Emotii technology system, showcasing his commitment to advancing the applied science of affective determinants of health. Now, without further ado, let me introduce our podcast guest, Brian K. Sullivan. Welcome, Brian, and thank you for joining us.
Welcome, Arvind. I'm happy to be here.
I am so excited to have this conversation. This field of healthcare is my favorite, and you've had a remarkable career from being president of the South Carolina Psychological Association to your current role as the Chief Science Officer at ADoH Scientific. Can you tell our audience, how has your journey shaped your perspective on the intersection of psychology and healthcare innovation? We'd love to know more.
Well, thank you. So it is always surprising to realize just how long I've been working, because I still enjoy it so much. I tell students and other folks that I still look forward to going to work almost as much as I look forward to leaving it and coming home. And that's no slight against my home life. I have practiced applied psychology and taught and conducted research and supervised a great number of up-and-coming mental health professionals. And so I've had my hands in lots of different domains. And then along the way, I've also learned a few things about entrepreneurship, and I've done so at the intersection of psychology and healthcare proper. So many of us psychologists practice in relative isolation, and there are benefits to that, but there are downsides. And one of the downsides is that we don't often appreciate as much the other elements of our patients' well-being, including their physical health. And so being able to work more collaboratively with physicians and other healthcare providers and allied healthcare providers has taught me a great deal. And I'm still an active learner. I'm a perpetual student. And one of the domains that has caught my attention and really converted me into an evangelist is the field of affective determinants of health, which is at this point still relatively not well known. It's a little better known in the field of health psychology, and I did not cut my teeth in that domain, but I am becoming more and more interested in the field of health psychology as an adjunct corollary and to some degree offshoot of clinical psychology. And especially in the domain of prevention, trying to catch people with difficulties early and get them identified and get them connected to appropriate care to keep things like chronic diseases from onsetting and becoming worse.
Fantastic. No, that's really amazing. When did you know in your career that this is what you wanted to do? When did you know you wanted to become a psychologist?
Well, that's long story short. I was one of those people who entered college with very, very little idea about what I wanted to do to work. I was very much living in the moment, and I happened to do well in school. So I was pretty good in English, and I was good in mathematics, and I was good in science, and et cetera. When I visited Clemson University as a high school student, I saw a mechanical robot arm. Clemson University has an outstanding engineering department college. And I looked at that and thought, robots, yeah, that looks cool. I'll do that. I'll become a mechanical engineer. So that's what I signed up for. That was how I was admitted. And in my first semester, they required me to take a course in Fortran. I'm not sure how much Fortran is used anymore as a coding language, but I quickly learned that anything that anything that was going to fail because I misplaced a semicolon, I didn't want anything to do with that. I had no interest in coding. I'm not that exacting a person at that level of detail. My beautiful wife, is a software developer. And so I greatly respect that she is able to learn diverse coding languages and master the conventions and think creatively. I don't want to be an engineer. I'll be a professor, but what will I teach? Little did I know that as a professor, I wouldn't be teaching everything. I'll teach something that requires me to go through all the steps, mathematics. So I changed my major to mathematics and dove into that. I was fortunate enough to have a roommate randomly thrown together day one as freshman, named Steve. And Steve was intent on becoming a psychiatrist. So he was double majoring in psychology and chemistry. And every day he was coming home talking about things that were interesting, very interesting, and much more interesting than mathematics, thinking logically. He was talking about things that were so much more interesting and foreign to me. I then went on and accidentally registered for a higher level course in research, analytics, breaking down research, looking for alternative hypotheses. In fact, I think that was the name of the course. It was alternative hypotheses, and the book was called Rival Hypotheses. And it was a group of only 8 or 10 of us sitting around a table, taking research papers and reading through them and trying to come up with as many different ways as we could to critique the methodology and the premise and the conclusions. That was great fun. Then I took a course in human sexuality. That, of course, was fascinating. And after about 2 years, I realized I like mathematics, but I'm really enjoying psychology. So I changed majors again, much to my parents' chagrin. And from there, I never looked back. I was blessed with good professors and advisors, applied to graduate schools and was admitted. And from there on, it was Katie bar the door, because increasingly just being able to focus in on psychology and not Spanish courses or English courses or history courses, although all of those come into play, just being able to dive really deeply into human psychology and learning about comparative animal psychology and realizing that's not anything I even knew existed in the world. Learning about human behavior by studying other animals and their physiologies and pharmacodynamics and all of those sorts of things. Well, it has remained fascinating. And the more that I do it, the more enamored I become. Little did I know at the time that my work in a college counseling center at the College of Charleston would so greatly inform me as to the value of collaborative care. In a counseling center, at a college or university, you often have psychologists, social workers, professional counselors, and folks from other fields of well-being, wellness, academic performance, student advising, often up and down the same hall or in adjacent offices. And the value of being able to just take a student and walk them right down the hall and make a warm introduction to someone else who might have a specialization in art therapy, which I knew nothing about, but realizing that maybe this person would do a better job than I would because this student had an interest in expressive arts or dance or something that was affiliated. And having them walk students up the hall and bring them to my office and say, Doc, I think we need to do a little bit of assessment here, and that's outside of my wheelhouse. Could you help? Just being able to directly, collaboratively, cooperatively work together really shaped the way that I wanted to approach things from there on. So that led me down the road eventually to establish an analog in private practice, where I was aiming to create a similar sort of one-stop shop, because sitting with patients for 45, 60 minutes at a time I had an opportunity to learn so much about them, including learning about needs that they had that I couldn't possibly fulfill, like needs for financial advisement, needs for nutrition counseling, needs for physical therapy or physical activity, physical personal trainers, um, law. I would frequently have to say to someone, that's outside my wheelhouse. I'm not an attorney. I think you should probably talk to an attorney. So I set out to create a one-stop shop wherein I would have mental health professionals, including a psychiatrist and some addiction specialists and child adolescent specialists. But I also had a family law attorney, an executive coach, and I was canvassing to find an independent financial planner and perhaps a yoga instructor or personal trainer to join us and create that same sort of genuinely one-stop shop for all things pertaining to lifestyle and well-being, not just focused on psychopathology, but also focused on, and the idea was if I was counseling a couple who were arguing about money, then I would be able to call up the financial advisor down the hall and say, hey, could you come sit with us for a few minutes? With patient's permission, of course, but could you come sit with us for a minute and listen to what's going on here and let us know whether that might be something that you could do that I can't do that would advance us. And maybe the couple would move down the hall and sit in their office, or maybe they would just stay in my office and we would all talk together. I was unfortunate enough to be pursuing that just before the Great Recession, and I nearly lost my shirt. I wound up in a bankruptcy attorney's office, wondering if I needed his services. Fortunately, that did not come to light. But before that happened, and I had to scale down a little bit, which was a fortunate event. I'll say more in a moment. Before that happened, I happened to catch the attention of some folks at the American Psychological Association, specifically a sister organization, the practice organization of the American Psychological Association, who was interested in advocating and promoting more collaborative and integrated care practices. So I was brought to Washington and sat on a panel, got a little visibility for that sort of thing, had a very nice write-up at the time. Little did any of us know that the Great Recession was right around the corner. And so when I had to scale back from the one-stop shop vision, I had begun to discover that I was an early adopter of electronic healthcare records in psychology, something that had already taken hold and was up and running in medical practices, but psychologists were slow to adopt that. I was an early adopter of not only that, but years ago before iPads, there was something known as a slate PC, and it was a screen and a processor, but without a keyboard. The keyboard was on the screen. This was an early precursor. I was an early adopter of a slate PC on my lap, taking notes directly into the input system there. I was an early adopter of PDAs. Do you remember PDAs, personal data assistants? And I was using those for biopsychosocial entry. And unfortunately, at the time, that was infuriating for patients because they had to use a little stylus about this big and the screen was about this big. That was actually, not long after the advent of the internet itself. But I discovered I was an early adopter and a little bit comfortable on the bleeding edge of new technologies. And that helped to pave the way for me to become dissatisfied with a lot of what I was using. It was too clunky, it was too siloed. And that started me on a path of wanting to bring more resources together in an integrated fashion, break down silos between data sets, and also just expedite and support the efficiency of practices by automating a lot of things, by increasingly relying on electronic measures. And of course, the internet was growing up and maturing at the same time. And all of that came together about 12 years ago when I was having patients fill out questionnaires when they come into my practice. I would have them fill out questionnaires so that I could get up-to-date information about their recent mood and their recent sleep, appetite, energy levels, other activities and experiences. And it was good data. I was an early adopter of progress monitoring and outcomes measurement for psychology, something, again, that had already taken root in medicine, but was very slowly coming on board in psychology, largely as a function of my role as the federal advocacy coordinator, because I had the opportunity to go to Washington each year for a large conference where we were introduced to these things. And so I adopted these measurement tools, and they were lovely because they were very well designed and very well validated. And I discovered patients hated those too. They didn't just hate the stylus and the little screen, they disliked having to sit for 5 to 10 minutes filling out a lengthy questionnaire. And I thought, wouldn't it be nice if I could just hand them an iPad with visual graphics depictions of the very things that they most frequently wanted to talk about? Differing circumstances, differing personal variables, but so many common denominators, in as much as people were every session coming in and talking about stress. They were talking about anxiety. They were talking about depression. They were talking about feeling irritable and accidentally pushing people away. They were talking about fatigue and about not feeling well, somatic symptoms. And I thought, wouldn't it be nice if I could just hand them an iPad or an analog to that, and there would be visual depictions of these constructs. And I would minimize the time by just focusing down on the most common denominators, and I would allow them to use their finger to adjust the graphic in its intensity. So have a depiction of a neutral face labeled depression, touch that face, drag your finger, and watch that face become increasingly depressed until it was dramatically head hung low, eyes sagging, jowls, and capture the data on the back end. Don't ask people to use numbers, 1, 2, 3, 4, to tell me how they feel. I literally had a patient at one time put the pen down on the clipboard, and he said, "Doc, I don't feel in 5-point gradations." Yes, sir,
Wow.
I understand, but that's the best we have. And that was part of the impetus for me to want to create a GUI, graphical user interface driven methodology for capturing emotions and moods and other highly subjective experiences like pain, but doing so in a much more engaging manner. Emojis were coming along. You and I grew up in a period where we first began using emoticons by typing them, and then moved over to emojis. Emojis became the fastest growing language on the planet. And now we all use emojis. It wasn't that long ago, folks looked at anyone over the age of 30 and said, if you're using an emoji, you're not to be taken seriously. And yet here we are 10 years later, and we're all using emojis. Well, I took the concept of emojis and said, I want to create something different. And right now, then the manifestation of that idea is what we call Emotii. And emotis are GUIs. They're little graphical images, and they look like emojis, but they aren't, because emojis are designed by visual graphics artists working for different companies with operating systems like Apple and Microsoft. Emotis are different because we design those in-house, and we actually validate them to represent specific constructs like stress or pain or depression. And we just allow people to adjust the image until they hit that Goldilocks moment. That's too much, that's too little, that's just about right. That's how I'm feeling today. That's how I've been feeling for the last 2 weeks. And then the quantification happens in the background. And lo and behold, across time, I discovered the field of affective determinants of health, which has actually been around for about 40 years and actually has roots back going more than a century, but not called by that phrase. And realized, oh, well, in capturing this relatively tight set of common denominators, I have accidentally backed my way into capturing and quantifying some experiences that are of vital importance. And I say vital importance because they are impactful and correlated and perhaps even causal in 5 major domains of our functioning. 1, they may be representative of mental health disorders and diseases, or at least representative of clinically significant distress and difficulties and discord. 2, they are harbingers and or symptoms of a wide variety of chronic diseases, not the least of which being cardiovascular diseases and cancers and endocrine disorders, a wide variety of diabetes, if I didn't already mention that. Oh, wow. So it's not just important for me to help my patient feel less depressed. In doing so, I'm helping to actually lower a risk factor for a variety of chronic disorders and diseases that they may experience later in life if they aren't already experiencing them. I may be looking at symptoms of a chronic disease that I'm not prepared to recognize, but when I communicate those results to an endocrinologist or to a primary care doctor, they're in a position to say, It's not just depression. That depressed mood is actually artifactual to something else. And so that collaborative capacity to do a better job for our patients and to improve outcomes at the moment, but also to help reduce risk. So the third major domain in which they are invoked is treatment adherence. So patients not following their treatment plans, not taking their medications, not exercising as prescribed, not doing their physical rehab exercises that they're supposed to, as well as just everyday exercise. Treatment non-adherence is a multi-billion-dollar problem in this nation. And it was something that I was not taught about, not really aware of. But these few factors that we look at are all, to one degree or another, negative impingers against treatment adherence. That is to say, people who are depressed tend to have lower treatment adherence than people who are not depressed. So when you treat the depression, you actually help lift their capacity to more faithfully and consistently follow their treatment plans and to get back on the boat when they've fallen off. The fourth major area where these things are so vitally important is experiences like fatigue and pain, anxiety, irritability, loneliness. There's a lot of research coming to light on the deleterious effects of chronic loneliness and social isolation. Cigna did some research a few years ago during the pandemic, and their conclusion, just as a one-liner, was that chronic loneliness as a risk factor is as powerful as smoking 15 cigarettes a day. And yet, when's the last time your doctor asked if you've been lonely lately? It's not commonly applied yet. That research has not found its way. It's not been translated into day-to-day practice for mental health practitioners, for primary care practitioners. So these things drive maladaptive health behaviors. We don't like to feel bad. We are motivated to reduce or eliminate or avoid uncomfortable feelings: depression, anxiety, irritability, pain, fatigue, feeling simply physically ill. So what do? We go to bed earlier and we get up later. We sleep too much, although we may be having difficulty sleeping through the night, ironically. We over-rely on molecules like alcohol, cannabis, opioids, because we want to feel better. And so we're using those moment-to-moment, hour-to-hour, day-to-day coping strategies that unfortunately carry such a high cost, especially in the long term, and that create their own problems. So this relatively small handful of affective determinants of health that we focus on are drivers, unfortunately, of efforts at coping that are, in effect, maladaptive coping strategies. They are deleterious to our long-term and broad-based health. And then the fifth major domain, which is of great interest, it also turns out that these factors are associated with elevated risk for low productivity at work, absenteeism, presenteeism. They are also risk factors for burnout and eventually for job loss, job turnover. And so the enterprise sector of the world, not just those who are paying for their own healthcare and bearing that risk, there is interest from them, but also simply at the level of helping support employees' well-being and their productivity and cut down on job loss, turnover. I did not know. I wish that I was smart enough on the front end to know what I was getting into. I wasn't, but I'm so thankful that the domain of affective determinants of health exists at all, and I'm standing on the shoulders of other giants. But the problem has been that this domain of largely diffuse and largely academic research has not really found its way into practically applied, in the trenches, day in and day out, healthcare and workplace wellness. And so that is my mission and the mission of my colleagues, to bring that research into simple, efficient, and engaging methodologies to capture better data on these vital domains from more people more frequently. That's what I tell people all the time. I invented Emotii as a method to capture vital data, concise data, do it quickly, and do it in a way that isn't so tedious or annoying as traditional questionnaires.
Lovely. No, that's fantastic. Thank you for explaining what triggered you to, further study this field, and why you get out of bed, and what keeps you going, and why you're so excited about it even now. And I think this is in line with all of what I've discovered myself as well. I'm fascinated with entrepreneurs, people who get a little bit of success, create a company, and they're able to really affect a lot of people's lives through their products. So I love that, and that's why I follow them. And what I've noticed is that a lot of the successful entrepreneurs may have this in common. Of course, they may have their advanced degree in their field, whether it's software engineering or biotech or electrical, whatever it is that they may be specializing in, that product knowledge. But then also, almost all the entrepreneurs have this human theory, this interest in psychology, whether it's from evolutionary biology or something. They have this strong faith in something that they've observed and noticed through evolution, and it's fascinating, and that's why there is a lot of interest that I have as well in learning more. I mean, what better knowledge than understanding how other people think and how to get through to them, how to collaborate, because whatever little good has come or success has come, it's mainly because of other people. It's because of, collaborating with other people, because of their knowledge. And so it's fascinating. And I totally understand why you would be in this field and why it just, keeps you going, because I am super fascinated through in this field as well, reading books, on self-help and, actual evidence-based strategies on not just longevity and happiness, but across the board. I mean, on so many different areas. This is just, fascinating. So this is great because you mentioned about what led to the co-invention of Emotii technology. So that's fantastic. And, obviously once we have enough of that data, then it can have a huge impact in healthcare analytics. And that sounds super inspiring. Now, you also have LifeWorks. So is that the company that's that multidisciplinary practice where
Yes.
patients can come in? Okay, got it.
Yes.
So then you have these three key areas. Then ADoH, that takes a lot of your time, obviously. Then the invention of the Emotii technology, and then that's delivered through LifeWorks, and that's how you're able to practice these psychology-led integrative care type, mental health services that you're able to make available for your patients. Okay,
Yes,
got it.
I use it in my practice, and I've been fortunate to help guide mental health and medical providers to adopt the technology and to help us to experiment and to refine the technology and to begin building the database that will yield the novel insights that we know will come. And I'm prepared for surprises. There's a lot that I expect to emerge from the data because the existing literature tells me to anticipate that. But I can't wait to encounter that which could not possibly have been predicted in the absence of the data.
It can be life-changing for so many people, because you mentioned in our discussion as well, the substance abuse problem is obviously, growing. And the way you describe it as well, it's really, as a human, you want to avoid all of the unpleasant emotions, and that's how you develop that aversion, and you would do anything to not feel some of those negative emotions, and that's what leads people to substance abuse and many other ways that they can harm themselves. So your involvement in combating illicit substances use is extremely critical in that case. And how can technology such as monitoring and predictive analytics play an important role in identifying and addressing substance abuse issues in real time? And before you answer that, also, by the way, there was this rehab center who contacted us to create their digital platform using, tools that would actually help restrict the person who's seeking that treatment, the addict. So if they're seen around any such establishments where they could, get alcohol, or if it's sex addiction, then near strip clubs or any of that, or blocking things on the device itself that they can access certain sites. So creating that environment. But we gained a lot of knowledge, understanding some of that. But if you could throw some light on what are some of the new ideas on combating this challenge of illicit substance use.
I have so many colleagues who are so much more expert in this than I am, but I'll say what I can. Years ago, working at the College of Charleston and conducting evaluations of students who thought they might have ADD or ADHD or a learning disorder. Again, just by observation, my colleagues and I noticed that students were coming in, and these were folks who had been admitted to college, who in many cases did not have terrible grades, not even bad grades, would come in and say, oh, I think I have a learning disorder. I think I have ADD. And of course, we said, okay, well, let's find out. And we would get test results that were odd in the sense that on paper, according to the scores, a lot of these folks looked awful. They looked as if they couldn't possibly do very well in the demands of a college environment. In some cases, they looked as if they might have a moderately advanced case of dementia, memory scores that were awful, attention scores that were awful. And we got curious. And we said, what's going on here? Again, little did I know at the time that the assessment of malingering, of exaggerating symptoms, of faking symptoms might be something that we needed to pay attention to in college counseling centers. Well, in legal contexts, this sort of thing had been well established and there was good research available, but it had not been researched as an artifact in college counseling students. So we borrowed a couple of methodologies from medico-legal applications and incorporated those into our assessments. And lo and behold, we collected data for 4 years. And when we looked back, we found really strong evidence to support the idea that some students, unfortunately, an alarming percentage of them, were at least exaggerating, if not outright fabricating, their complaints and their symptoms, and actually performing poorly. We would give them computerized tests of attention, for example, and they would perform so poorly, so terribly poorly, far out of line with their everyday function, and far out of line with what the normative data would suggest we would see. And we had no alternative but to conclude that we were not seeing valid data. Again, here's a common denominator across my career: the quality of data. Biased data leads to incorrect conclusions. Garbage in, garbage out. So we realized these students were going out of their way to produce misleading data, or at least greatly exaggerated data. We published that research in 2007, and we were among the first in the nation to do so. And other researchers quickly followed suit and began revealing, oh my, at our college, when we use these methods, we began to see some of the same results, and they started contributing as well. And now it's fairly well established, that area of research. It's not anything I'm involved in anymore. Well, how does that inform us now? Folks don't like to be in pain, of course. They don't like to be in distress. They don't like to suffer, especially when it is chronic and persistent and they can't figure out healthy ways out. I believe that by combining data from clinical records and from passive data collection like social determinants of health, as well as directly asking how they're feeling, affective determinants of health, etc., we will derive novel ways to detect folks who might be exaggerating or even malingering their difficulties, as well as detecting when people are trying to put on a strong face, a good face, and hide the degree of their actual suffering or risk vulnerability. And those will emerge as we develop better methods. For example, with our technology, a person moves their finger on the screen to move a slider that adjusts the image. And by paying attention to how long do they actually spend manipulating the slider, how many times do they shift direction before they center in on the final data entry for that particular domain, we may be able to detect relatively subtle, because we're looking at milliseconds, right? And we're looking at millimeters. We may be able to pick up on subtle indications that they're either rushing through the test and not taking it seriously. Do they always push everything sort of biased over to the right side of the screen or biased to the left side of the screen? Are they answering in a way that doesn't actually make sense? You're rarely going to see someone with severe pain who isn't also feeling sick and or fatigued or stressed, because pain is stressful. And if they move the slider all the way over here and say, no, I have no stress at all, but all the way over here to say, oh, I'm in severe pain, doesn't really add up, does it? So it at least begs the question, did the person rush through the test? Did they have a bias in their responding in some way? Not necessarily because they're trying to exaggerate or minimize, but maybe because they were simply inattentive. Maybe they don't have a high degree of trust in the healthcare provider. That's an important determinant of healthcare outcomes, is the degree of trust folks have in their specific provider, in the system altogether. So I think that we will be able to combine various methodologies to produce less biased data, or at least to highlight when we ought to pay more attention to potential bias in the data.
And all that comes by the use of AI, of course, better tools to analyze the data, and that's how we can combat, the substance abuse. And of course, I mean, a lot of it through, traditional ways as well. I know technology, of course, can have a huge impact, but just, meditation. Like if somebody in my family was struggling with this, I'd say, I mean, there's a joke around that for everything, the answer is drink more water and meditate. Drink more water and meditate. I mean,
And
that's
sleep
usually,
better. Sleep better.
I know that's an important one as well. And
It is.
no, but I think with technology and AI, and I think there can be these improved assessment processes, and there can be different safeguards that can ensure, the right outcomes and diagnosis as well. Another very important technology that I'm excited about is, driving innovation is the VR and AR with the Apple Vision Pro. They're terming it as spatial computing, but I feel like those technologies with those experiences, can be harnessed to improve mental health treatments and therapies. I'd love to hear some of your thoughts on how we can use AR, VR in mental health.
So two major applications, one of which already has a pretty good history at this point, and that is the use of augmented or virtual reality in exposure therapies. With augmented and virtual reality, we are able to create or replicate an immense variety of environments that would otherwise be difficult to replicate or to access, and do so that the patient has an in vivo experience of an environment that they're able to visualize and listen to and participate, place themselves into. And, it's not just the opportunity to create that artificial or augmented environment in reality, it's the opportunity to hit pause. It's the opportunity to back up and go through that sequence another time, back up to a different point and go through that sequence another time. The exposure therapy domain as an application for augmented and virtual reality, there are already folks doing a lot of work there, especially with military veterans, for example. That's one that already has legs. The other one that I'm excited about is, we already are seeing a lot of folks make efforts to create digital therapeutic assistants, chatbots. And there's a company out there, I have no affiliation with them, but they're called LEQ. They have a desktop robotic type device that is geared primarily, or at least its origins were for shut-in, lonely, elderly folks as a highly interactive method for cognitive stimulation, for company, for engagement. And now they're extending that technology into other populations and other applications. That one continues to fascinate me. They seem to be on the forefront. But other folks who are creating, using generative AI to create simple chatbots. I had somebody reach out to me on LinkedIn just this morning. They reached out at 3:53 a.m. I don't know where they are, but I woke up this morning. Somebody had sent me a message on LinkedIn saying, "Hi, you seem to have the sort of background that we think would be helpful. My friends and I, we've gotten together, we've created a digital therapeutic assistant, a chatbot, and we'd love to get your impressions." So I'm giving it a try, and it's probably the 8th or 9th one that I'm giving a try. That's very exciting to me, and we have a long way to go. Well, we have some ways to go. I'm not sure how fast it'll go. Hopefully it'll accelerate very, very quickly. Creating experiences that at least closely mimic what we get in talking with real people. Because for one reason, in my mind, and one reason only, there aren't enough shrinks, and there's not enough access, and there's not enough affordability for so many people, and not just in the United States. So if we can create virtual reality that increasingly closely mimics truly caring, sensitive, thoughtful, respectful, non-defensive, and ethically responsible agents, virtual agents, then a lot more people are going to be helped at incredibly small incremental costs. Once you've developed the base, then adding each additional user, it's a very, very small incremental cost to do that. So that potential is not yet what I'd like to see it be. And I'd like to see good people researching these, evolving. That's one problem we have with digital therapeutics, is there are so many out there and they have no research base whatsoever. I'd like to see more and more acceleration in that domain of virtual therapeutic agents. And I'd like to see good research critically looking at whether or not they are effective beyond a placebo effect.
Absolutely. No, digital therapy, oh my God, that is something that I am most looking forward to. As I mentioned, whenever something goes wrong, I go back to, okay, well, you should drink more water and meditate, right? And then sleep more. But this is also something which seems to be pretty common when I'm trying to help a friend or give anybody advice. Of course, it's not like, oh, you need therapy. No. So that's why I say everybody needs therapy. I mean, look at Michael Phelps achieving Olympics gold through therapy and talking about it, and many other really high achievers. This is really to help you like you able to perform to your fullest potential. I mean, it's just something that can be extremely, extremely important, can change your life. And, that's why I feel like this needs a lot more research. I mean, imagine if all of the different therapy sessions without personally identifiable information could be used as a training set. Mm-hmm. And yes. I mean, when I was getting therapy, it was great because I would get these exercises. I mean, even though they were on Excel, why can't we have that on the mobile app itself? And, it's about teaching certain concepts. I mean, it could have that networking effect with your friends. I mean, sky's the limit. And especially with, Vision Pro or any other of those, devices for extended reality. I mean, it's mind-boggling. And I mean, imagine the impact it could have on people and their productivity. So I can't agree with you more on, the scope of VR and AR. I mean, somehow it picked up, but then it hasn't done as well. But I think the application for digital therapy can also be through virtual health and telehealth, right? It could be an avatar, as you mentioned. But with the rise of telehealth and remote patient monitoring, how do you envision technology bridging the gap in mental health services, particularly in reaching underserved or remote populations? As you mentioned, I mean, of course, within the US as well, there are so many areas that are remote with limited connectivity. But then when you open it up for the entire world, when you're considering, the conditions that a lot of the developing economies are in and the stigma that's associated with this therapy as well. I think, the younger people, of course, are now completely understanding of this, I feel like, but there's still in the developing nations that stigma that's associated. So share your thoughts on that, if you don't mind, Brian.
Well, I'm in Charleston, South Carolina, fortunate to be just a couple of miles away from the Medical University of South Carolina, where they are doing some wonderful work on developing and advancing telehealth. It is self-evident that through our cameras and our speakers, the internet, you and I are able to sit in completely different areas of the nation and have a conversation in real time. Being able to allow folks who otherwise would have to drive too far, who are mobility limited, and especially as a cost factor, being able to access qualified and caring professionals to support, help their healthcare, their health status of such and their well-being across such a wide domain, that ball is now rolling so assertively forward, and it's exciting. And again, often those platforms and those methods are siloed, and just getting integration between a given EHR system and a given telehealth video platform. These two systems won't talk to one another, but I've had this one for 10 years and I really like this one and I want to be able to use them both, but they don't talk to one another. We've got to be able to break down more silos and to do so in ways that provide true access, not just proprietary access. So accuse me of being a bit of a bleeding heart, but we have to make healthcare not just more easily, but more frequently accessed while maintaining costs so that it is affordable for people to do so. So I'm excited to see telehealth. I use it with my patients selectively. And then being able to augment the teletherapy with digital therapeutics, with a chatbot offline, with remote monitoring through your smartwatch, using Emotii or some other method for being able to monitor, and incorporating that with biometric data, momentary ecological data through heart rate variability monitoring, in addition to self-report, in addition to AI looking at the data and deriving an insight to alert the healthcare provider that we don't need to wait until next Wednesday for that appointment. We need to have that in the morning because their cardiac risk factor just went up by 9 points in the middle of the night, which we happen to know is a frequent time for folks to have heart attacks.
Absolutely. Absolutely. There's so much that can be done. We're truly in unprecedented times. And so looking ahead, I guess, what are the emerging technologies in health tech space that are most exciting for you besides, what we've talked about? I guess there's, of course, AI, there's AR, VR, that's extremely important. But are there others that you think might transform the landscape of mental health and wellness in the coming years?
It isn't sexy, but I will be frank. The emerging technology that I believe has the most potential and is the most needed is interoperability for different platforms to be able to operate together, and for patients' convenience and for providers' convenience and for the data, ethically responsible use of data to be more broadly available to a wider variety of folks who can look at the data and derive insights and apply methodologies like machine learning, and for providers to have real-time, accurate, broad access to where the patient has been recently, whether or not they've been active recently, which other providers they've been to, what were the results of those visits. I still occasionally get my phone will ring at my office and someone wants to send me a fax as a referral. We have a long way to go, but interoperability, solving those problems, and they are big problems. There are lots of variables involved there, but solving the interoperability problem and making broader, more accurate, and more real-time data available from a population health standpoint, from an individual provider standpoint, and making it available to consumers themselves to be able to initiate their own actions.
And drive innovation and come up with these new ideas and new insights. And I think data is king. Well, that's super fantastic. I love it. Thank you so much again. And there you have it, folks. We just wrapped up yet another roller coaster of insights on health tech innovation trends 2024-25 podcast series. Big shout out to Brian for dropping knowledge bombs that left us all in awe. I don't know about you, but I had a blast during our chat. It's like we were riding the wave of future together, exploring the uncharted territories of health tech. Brian, you're a rock star, and your insights were the highlight of this episode. Now, dear subscribers, if your brain is buzzing with excitement after this mind-blowing discussion, don't keep it to yourself. Share the podcast love with your friends, and let's create a ripple effect of innovation. After all, good things are meant to be shared. Stay tuned for more such mind-blowing insights from industry leaders. Until next time, goodbye.